The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
Thank you all for taking the time this evening to listen in. I appreciate your time and look forward to hearing your questions at the end. I'm going to give a short presentation here about erectile dysfunction, what it is, who has it, and what causes it. So what is erectile dysfunction? So I think each man and each couple can really define what erectile dysfunction is for them, but the medical definition for us is the persistent inability of a man to achieve and maintain an erection adequate for satisfactory sexual intercourse. It's very common. So 1 in every 5 men over the age of 20 has some degree of erectile dysfunction, and as men age, erectile dysfunction becomes more common. So more than 50%, so more than half of men over the age of 40 have ED, which ends up being about 39 million American men. So many of the underlying and comorbid conditions, men's medical disease processes often will affect their erectile function. So things that can often affect erectile dysfunction are cardiovascular disease, diabetes, different medications, and very commonly prostate surgery. If you think about erectile function, I normally think about it as a blood flow issue. The most common reason that a man won't get a sufficient erection is because blood doesn't flow into the penis as well as it once did. If you look here on the right of the screen, it shows a demo or a model of what the size of the erectile dysfunction arteries would be inside a man's penis. So the penile artery is normally 1 to 2 millimeters in size. You compare that to any man who has a history of heart disease, and that means that they had blockage or obstruction of the blood vessels in their heart. Those blood vessels are 3 to 4 millimeters in size. And if a man has a history of stroke, often they have narrowing of the blood vessels that go up in the carotid artery. Those blood vessels are 5 to 7 millimeters in size. So blockage of those vessels really does correlate very strongly with men having blockage of the blood vessels in the penis. So when I think about the erection process, it normally starts up in your head. You have to be in the right environment. You have to have a low stress. Often having the right amount of testosterone helps a man have the amount of desire that they'd like. Once that signaling then leaves your brain to go down to your penis, you have to have the normal blood flow, like I mentioned before. So what happens is those nerves then get down to the penis and stimulate the blood vessels in the penis. So when I think of the penile anatomy, it's really made of 3 tubes. There's the 2 erectile bodies, which are these 2 things on top. Those are the erectile bodies, or cavernosal bodies. They have 1 main artery that goes through each one, and small veins then surrounding it. On the bottom of the penis is the urethra. That's the tube that you urinate through. When the nerves stimulate the penis, those arteries open up and blood then flows into the penis. The muscles around the arteries relax, and then more blood can then fill in, causing stiffness or hardening. The veins also push against the sheath that keeps the penis intact, and therefore those veins prevent leak. Those veins are compressed and there's not much leakage, and therefore the erection tightens the veins. The penis becomes erect and maintains erect until the completion of sexual activity. So the most common thing that we discuss as the first step for treatment of erectile dysfunction are medications. And the idea of medications are to allow for more blood to flow into the penis and allowing the corpus cavernosum, or that sheath inside the penis, fill with more blood. Very commonly nowadays, I think men will talk about erectile dysfunction differently than even when I started my practice. And I think more and more the primary care doctors and other physicians are become very comfortable on who can talk about erectile dysfunction. So what I've found is that many patients who already are established with a PCP or a general practitioner or a family doctor can really start the conversation about their erectile dysfunction in that setting as long as they feel comfortable. Many primary doctors feel comfortable writing for pills to help with erections or checking testosterone levels to make sure those are normal. Often though, and if you see, the number of men that have erectile dysfunction is so large that there are a large percentage of men that the pills on their own don't help. Or you really want an expertise in what the whole gamut of options are. And if that's the point where it makes sense to talk to your urologist, or especially talk to someone who's a prosthetic urologist, someone like me or many other people around the country who specialize in treatment not only of erectile dysfunction medically, but also treat erectile dysfunction surgically. I'm going to take the time now to really talk carefully about all the available options that are out there for erectile dysfunction. So when I think about what's out there to treat erectile dysfunction, the first thing we usually discuss are pills, oral therapy or PDE5 inhibitors. These are things like Viagra, Cialis, and their generic counterparts. Intraurethral suppositories or gels, which are medications that are deposited into the urethra, injections into the penis to allow blood to flow into the penis more easily, vacuum erection devices, which are cylinders that go outside the body and pull blood inside into the penis to give an erection, and penile implant surgery. Not covered here is our wave therapy. Wave therapy is a newer therapy that allows for small pulse waves to go in the penis and allow some of those blood vessels to be repaired. That's an off-label therapy that has been shown in some studies to help as well. I'm going to talk in more detail about these 5 things that are covered. Oral therapy with PDE5 inhibitors. Oral therapies or pills to help with ED are really common. For the last 30 to 40 years, these have really been the first line of therapy to help men achieve erections. The most common therapies that we usually try first are sildenafil, which is the generic form of Viagra, or tadalafil, which is the generic form of Cialis. The way these medicines work is they allow the blood vessels in the penis to be more excitable with sexual activity. If you take a pill like this, it does not give you an erection right away, but it allows with stimulation for the erection that you will get to be firmer and better. Depending on which medication you take, the timing is a little bit different, but normally they take an hour or 2 for the medications really to get into your system. They enhance how much of the blood will flow into the penis, and they require sexual stimulation, like I mentioned. Viagra or sildenafil typically stays in the body for about 4 hours or so. Viagra is really sensitive to food, so it's recommended that you take the medicine on an empty stomach, or it really doesn't work as well. I often see patients that come in and say, I take my Viagra with my dinner and it's not working. But it really works much better if you take that medicine on an empty stomach about an hour or 2 before planned sexual activity, and with sexual activity being somewhere around 4 hours or within 4 hours of taking the pills. Cialis is really nice because it's a medicine that stays in this body longer and is less affected by food. Cialis typically stays in the body for about 36 hours. There's 2 options of taking Cialis or tadalafil. This is either a low dose that you take daily or higher doses that you take prior to sexual activity. Like any medication, these are not for everybody. There are some interactions with alpha blockers, especially these medicines interact with nitrates. They can cause an unsafe drop in your blood pressure. When a man takes PDE5 inhibitors like Viagra and Cialis, there are potential side effects. The most common side effects are headaches, stuffy nose, nasal congestion, and some vision changes. Some men do experience heartburn or muscle aches or back pain with the medications. Most of my patients, if they try one medicine and have side effects, sometimes we can switch them to the other and not have as much of a side effect. Next thing I want to talk about is intraurethral gel or an intraurethral suppository. This is a needleless way of getting medication into the body. So this is a medication, usually alprostadil or phentolamine, which are deposited into the urethra and then absorbed through the urethra, which is the tube underneath the underneath the erectile bodies and then gets picked up by those erectile bodies. Usually this is inserted about 5 to 10 minutes before sexual activity. It takes a few minutes for the medicine to then get into the penile erectile bodies and be effective. In most studies, there's about a 65% success rate. There is some significant irritation and potential risk of bleeding from the penis when this is placed. The medication does need to be refrigerated. More commonly, and oftentimes, I will prescribe a man to use intracavernosal injection, where we teach a man in the office to inject themselves with a medication and deliver the medicine directly into that corporal body or corpus cavernosum. The way this works is this is either a solitary medication or oftentimes a combination of 3 medications, all that are designed to help blood vessels dilate and stretch to allow the penis to then fill. The medicine works very quickly, usually within 5 to 10 minutes, and the medication is directly injected into the penis. The upside of that is that even though it does need to be injected with the needle, the idea is the medicine only gets where you want it. So you don't have side effects throughout your whole body like you do with pills. The only affected area really is the penis where you want the medicine to work. The success rate is very high. In my experience, it's about 70 to 80% of guys have a really nice response with these medicines. We have it listed here a little bit higher, up to 90%. And there's different doses, so you can titrate up or down based on what medication you need. This medicine is very potent, and so therefore the most common side effect and the feared side effect of this medicine is that 4-hour erection that you hear about in commercials for Viagra and Cialis, which honestly you just see a lot more often with these injections than you do with those pills. The reason that I test most of my patients in the office, or at least make sure that they're in a supervised setting when they do these injections at first, is this risk of a longer erection. If a man gets an erection that lasts for 4 hours, it can cause permanent scar tissue in the penis, and therefore we really want to make sure that you are injecting safely and dose appropriately when you are doing these injections. That said, I have lots of patients that are very happy with these medicines, and despite using a needle, they get very comfortable using them. The medicine does need to be stored in a refrigerator and usually should be discarded within 28 days of your initial use. The next thing to discuss is a vacuum erection device. A vacuum erection device works a little differently than the other medicines we talked about. Those all work on stimulating your natural blood vessels to fill with blood. The way the vacuum device works is a cylinder that you see pictured that goes against the body, and then the penis goes in this tube, which is a vacuum. And what it does is it mechanically pulls the blood inside as opposed to the blood vessels dilating and stretching. What happens is there's 2 types, either a manual model that you mechanically squeeze a pump to pull the air out of the tube, or a battery operated model that you press a button to allow for the air to be pulled out. What happens is once the penis is inside this tube, the blood is then pulled inside mechanically, allowing the erection to be achieved. And then, as you see on the bottom, those small rings are placed on the base of the penis. You need to figure out what the right size is for you to allow for an erection that will maintain by having the ring on the base of the penis, but not so tight that it is uncomfortable. Efficacy depends on how you want to describe it. Patient satisfaction ranges somewhere from 60 to 80%. I'll admit in my practice, I can probably 90-something% of men get a good erection if this device is used appropriately, but it's more balancing the comfort of having that ring on the base of the penis and leaving that ring on during sexual activity. That is the deciding factor if a patient is satisfied or unsatisfied with this type of therapy. With that ring in place, it can cause blockage of the ejaculation. It can cause numbness or difficulty with sensation during sexual activity, and some men do have bruising from the ring or from the vacuum itself. Okay, so a vacuum erection device can also be used as part of rehab. I often prescribe this to men who had their prostate removed and aren't waking up and getting natural erections anymore. Often the vacuum device is used 3 to 5 times a week for 20 to 30 minutes at a time. What often happens is when a man has prostate cancer and their prostate is removed, they experience some loss of their penile length and can often get scar tissue formation in the penis because they're not getting natural erections in that 6 months, 1 year after their prostate's removed by using a vacuum device regularly. And I often will combine use of the vacuum erection device together with some of those pills that will allow for stretching the penis and hopefully reducing curvature or Peyronie's disease and reducing loss of length from the prostatectomy. And then the next option I want to talk about is a penile implant. So a penile implant is a surgical procedure where we implant cylinders inside the body, replacing the blood vessels that are naturally there inside those corporal bodies, those erectile bodies, with cylinders that are filled with saline or salt water. The most common implant is shown here on the slide. This is a device that has 2 tubes, one for each cylinder of the penis that is filled with saline or salt water, a pump that sits in the scrotum, and a small reservoir that sits down the pelvic or in the lower abdomen. The way this works is you squeeze the pump in order to fill fluid from that reservoir into those cylinders to get an erection, and you press a release button to allow the erection to go away. This does really mimic natural erectile function more than any of the other options, which is really nice. It's a very effective procedure with very high patient and partner satisfaction. What's nice is it's on demand, and you can leave the device inflated for as little or as long as you want. And at 7 years, 94% of men are still happy with their device in place. We normally say a picture is 1,000 words, and so if you look here in one moment, you'll see that here's a diagram of the way a 3-piece penile implant will work. It's the 2 cylinders that are there inside replacing the erectile bodies, the pump that sits inside the scrotum. When you squeeze that pump, the cylinders then fill with the fluid from the reservoir. You can then keep the penis inflated with those cylinders as long as you want, and then you press a small button to allow release of the fluid back into the reservoir until its next use. Placement of a penile implant is a surgical procedure, and like any surgical procedure, there is risk. So one, you should speak to your primary care doctor, and then definitely the prosthetic urologist that you're seeing about what your risks are of having a surgery, having an anesthesia for that surgery. Anytime we implant a device inside someone's body, there is a small risk of infection. What's nice about the inflatable penile implants, especially the Boston Scientific device, comes coated in antibiotics. Because it's coated in antibiotics, and we give preoperative antibiotics before we give antibiotics during the surgery and then antibiotics after the surgery. The combination of those things reduces the risk of infection of a penile implant down to 1 to 2%. That's still not 0. So we do everything in our power to keep that risk of infection as low as possible. If we put a penile implant inside, the average device lasts about 10 years or so, maybe 10 to 15, but there's a possibility the device will break down and will need to be exchanged. In my experience, about 95% of guys are very happy they had their implant placed. That said, there is a potential that you have a device placed and you're not happy with your outcome, either because of infection or postoperative pain or other issues with the device afterwards. Men with diabetes or spinal cord injuries or open sores do have a higher risk of infection, and therefore it really makes sense to have a sit down with your prosthetic urologist and talk about the pros and cons of placing an implant for you in particular and the different types of models. I'm definitely just scratching the surface on the discussion on penile implants as well as all the options for erectile dysfunction. There's definitely a lot more information available online at edcure.org, where you can talk to a prosthetic urologist team and get answers to questions about prosthetic urology. And this talk was produced together with Boston Scientific, who is the maker of the most common penile implant. The first thing I'll talk about is these injection therapies. So when we do injection therapy, the way I like to think about it is it's a very small needle. You get a vial like this. Every time you use the injection, what you want to do is clean the tip here, and then you take an alcohol wipe and clean the penis model. And then what you do is pull the appropriate amount of medication into the syringe. I don't know if you can see here very well. I have some patients that inject a very small amount, as little as about a 0.05 cc's, and I have some guys that inject as much as half or 0.7 cc's. Once the medicine's pulled in, you make sure there's no air bubbles and have the medication here ready. You can cap it and leave it for later, or do your injection. The way the injection works is after the penis is clean, into either the 10 o'clock or 2 o'clock position, the needle goes into the penis. And then once it's in, you place the fluid in. should take about 2 to 3 seconds to fill in, and then you take the needle out. Sometimes I'll take the alcohol swab and put pressure on the area of injection site because you may have a tiny bit of bleeding from where the shot went in. And then within 5 to 10 minutes, you should have an erection. The other thing I wanted to model is the penile implant. I hope everyone can see. This is that 3-piece penile implant, which is the most common implant we place. These are these 2 cylinders that sit inside the penis. They are connected to the pump and then connected to the reservoir. The reservoir either goes in the lower abdomen or down in the pelvic area. The only part the patient really interacts with is either the pump or the cylinders. What you do is you squeeze the pump. When you squeeze the pump, those cylinders then fill with fluid. And as you pump it up, you see you can achieve girth and length. The more you pump this device, the more you can fill. Your body will not allow you to overinflate the device. Then you can leave the devices inflated as much as you want. And then in order to release it, you press this button right here. By squeezing that button, it opens the valve back up, and then the fluid then shifts out of the penis and goes back into the reservoir for the next use. The penile implant device is completely concealed inside the body. So if you look at a model like this from Boston Scientific, you would say a patient that has an implant in place, you wouldn't know that it's there until you bring the pump up to the skin, and that's where this pump would sit. Did you want to open it to questions now?
Yeah, so we already have, if you submitted a question beforehand, we have those written down. We're going to do our best to get through as many as we can. So let's get us started with some general ED questions here. The first question I have is, what ED treatment options work best for men with venous leakage?
So venous leak is, as I described at the beginning, when the artery brings the blood into the penis, and then the veins have to compress and allow the blood not to leak out of the penis, and that's what allows them the erection to be maintained. Venous leakage is when those veins don't compress as much and then persistent despite having blood flow into the.
Let's get us started with some general ED questions here. The first question I have is, what ED treatment options work best for men with venous leakage?
So venous leak is, as I described at the beginning, when the artery brings the blood into the penis, and then the veins have to compress and allow the blood not to leak out of the penis, and that's what allows them the erection to be maintained. Venous leakage is when those veins don't compress as much and then persistent, despite having blood flow into the penis nicely, the blood leaks out back into the rest of the body. And so lots of men with venous leak will often say that no matter what therapy they do, they can only get to about a 70% erection. Because of that reason, the analogy I usually give my patients with venous leakage is thinking of it like filling a cup with water through a spout with a drip at the bottom. So no matter how much you fill, you're always going to lose some of the fluid. It'll never stay completely full. In my mind, most men with venous leakage don't really do so well with oral therapy, so pills, or do well with the injection therapy because if the blood vessels are normal, bringing blood in, it doesn't really fix the problem. So most of my patients with venous leak will either use a venous compression ring, so the ring that we use with a vacuum device, either using that with a vacuum device or in conjunction to pills or injection therapy. And I will say venous leak patients often will move faster towards a penile implant than other patients.
Alrighty, awesome. So next question here, I know you briefly mentioned this treatment method. It came up multiple times in our questions. So we had a lot of people wondering, how does wave technology work?
So wave technology is this low intensity shock wave therapy. The way it works in short is that it's a therapy session, and there's really it's not FDA approved because there really isn't a model or a plan or a device that has really been shown to be superior than to other devices. And currently, the American American Urology Association and the Sexual Medicine Society state that it's an investigational therapy, meaning that it shouldn't be used outside of a study. That said, nowadays, lots of practices and lots of institutions are offering wave therapy because it has been shown to work really nicely for men with mild to moderate erectile dysfunction. And what happens is these small pulse waves go to the penis. They allow the blood vessels that are there to be repaired to some degree, and also help with some neovascularization, so new blood vessels forming inside the penis, allowing for better flow. I found that it's really best for these guys with mild to moderate erectile dysfunction because it really shows about a 20 to 25% improvement of erectile dysfunction. And so if you have really severe ED, it really doesn't help enough to give a significant clinical benefit. But for guys with mild issues, I think it really does help nicely.
Alrighty, moving right along. Next question: can you recover from nerve damage caused by an erection lasting longer than 4 hours?
So if you have an erection that lasts for more than 4 hours, my concern is less about nerve damage and more in scar tissue that forms inside the penis. So that erection for more than 4 hours is considered a priapism. Usually irreversible and severe damage occurs if a man has an erection for 36 hours. That said, immediately after 4 to 6 hours is when that fibrosis and scarring and damage occurs. And what happens is that scar just stays inside the penis because the blood that's there scars and then doesn't drain well. And then what happens is subsequent attempts to have an erection, those areas can't then fill with blood in the future. So the more scarring you have from your prolonged erection or priapism, the worse the scarring will be and the more ED you'll have.
Alrighty. Saw this question multiple times. We have some patients with diabetes, different types of diabetes. They're wondering if there's any tips for men with diabetes and ED or hope for relief from ED.
Erectile dysfunction due to diabetes is very common, and unfortunately, men with diabetes often will have ED at a younger age than men without diabetes, and in addition, tend not to do as well with the pills as men who don't have diabetes. And so I would recommend that any man that has diabetes and erectile dysfunction, improving their glycemic control, so good control of your diabetes, exercise, healthy diet, things like that, all often will help your diabetes and help your erections to some degree. That said, I think the other therapies that we had talked about outside of pills are very common options for men that have ED and diabetes. Things like injection therapy tends to work really nicely for men with diabetes, because diabetic men, if they're comfortable with using injecting insulin, comfortable with needles, tend to do really well giving themselves injections, and because the issue with diabetes is often at least partially nerve related, meaning that the signaling doesn't get to the penis. If you can bypass those nerves and directly inject the penis with the medication, diabetic men tend to get a good response with injections. Additionally, a penile implant is a really nice option for men with diabetes, as long as their diabetes is controlled.
Alrighty. Next question here. Can physical conditioning as an exercise reverse ED sufficiently enough so that someone can go back to using oral medications for ED instead of other methods?
Like exercise? So I definitely have seen it. The concern is always if there is damage to blood vessels, either because of your underlying medical conditions like high blood pressure, high cholesterol, diabetes, things like that. Oftentimes that damage doesn't get reversed, but by working on your overall health, by working on your underlying factors, you can prevent those things from getting worse. I have seen some men get significant improvement, but unfortunately, oftentimes, if there's damage, sometimes that damage is done.
Alrighty. Next question here. Can erectile dysfunction be tied to your biorhythm? My ED seems to wax and wane in some sort of cycle.
I think that's case by case and person by person. I'll admit overall, I tend to look at the patient globally to say how often they're having their erectile dysfunction and what their issues are globally. If a man has 1 or 2 episodes where they wanted to get an erection and they didn't achieve it, then, but for the most part, they're doing well. We tend not to be aggressive about therapy. But I do think that lots of factors like stress, anxiety, poor sleep, just not feeling well, not being in the mood, also psychological factors like if you're fighting with your partner, things like that can affect erections and your overall desire to have sexual activity.
Definitely. Next questions here are going to be aimed towards the title of our event. Why may pills stop working for someone?
So the way the pills work is that they allow the blood vessels in the penis to be more excitable. So in some men, especially if they have an issue that's affecting the nerves, that signal to get to the penis just isn't there. So a man that had their prostate removed, man that has neurologic issues because of pelvic trauma or because of diabetes, that signaling doesn't get to the penis. And so if the pills don't work because the signaling telling the penis to work isn't there. And so that's why we often see failure of pills with men with prostate removal or prostatectomies and diabetic men. In addition, as we mentioned at the beginning, the blood vessel in the penis is very small. And what happens is those pills will often allow the blood vessels to dilate to some degree with stimulation. But if the underlying issues that are causing those blood vessels to narrow, be it just age or high blood pressure or high cholesterol or other issues, those blood vessels continue to narrow, then the pills become less effective.
Alrighty, kind of a follow-up here. Why might ED pills be effective at night or one night but not the next?
I would say one of the most common things that I see is dietary. So overall, what you mentioned before is that, yes, overall, there's a possibility that with time, a man's underlying cause for their erectile dysfunction worsens, and so your ED can worsen. But that said, if it's one night works better and the next night doesn't, that's probably more of a short-term thing. Either that you took the pills together with food, and especially Viagra really does, food can highly affect the ability of the pill to work. Two, if you are drinking alcohol, oftentimes pills don't work as well with alcohol. And then 3 is the other issues we talked about before: stress, anxiety, concentration, and things like that.
Alrighty. Next question here. So I know we mentioned that pills may cause some mild congestion. This person wants to know if injection therapy will cause the same.
Like nasal congestion?
Yeah, like nasal congestion.
No, it was really the upside of the pills. The upside of the injections over the pills is you really don't get any of those other side effects through the rest of your body. So nasal congestion, muscle aches, headaches, things like that are often the reason why men don't like taking the pills. You really don't get those with the injection therapy.
Alrighty. Moving right along. Does low testosterone factor into the failure of oral medications for ED?
It may. There is literature to show that men with a low testosterone don't respond as well to pills as men with a normal testosterone. So that's why, as part of the workup for men that come in with erectile dysfunction, we will check their testosterone. And if you have a low testosterone, normally we check a testosterone twice. If you have 2 levels that show a low testosterone and you're a candidate for testosterone replacement therapy, I would highly recommend it, especially if you're having erectile dysfunction as your only sign of low testosterone. Other symptoms of having low testosterone are feeling tired, feeling run down, fatigue, poor concentration, muscle loss. So lots of men come in with many of those issues, but some come in with just erectile dysfunction. And I think that would be an indication to try testosterone replacement. I do have men that have a low testosterone and required pills, and then we give them testosterone medicine and no longer require the pills. And I definitely have lots of patients that come in and say the pills are working much better once we've corrected their testosterone deficiency.
Alrighty. Last question here about PDE5 inhibitors. Are all generics the same?
So number one, the brand name medication and the generics should all have the same active ingredient. So number one, generic Viagra should work similarly to the Viagra, and generic Cialis or tadalafil should work similarly to the tadalafil, but aren't interchangeable. But yes, different manufacturers may make it a little bit differently, and I have heard patients complain that say one pill worked better of the same medication from one manufacturer versus a different one. But the idea is that they should be very similar because the active ingredients should be the same, but it's not a perfect science.
Alrighty. Moving on to some injection-aimed questions here. This person says that they just experienced a skin rash or abrasion on the head of their penis after using Trimix. Is this a common reaction?
Not really. I haven't really seen that too often. The most common side effects that we see with Trimix injections are bruising or discomfort right at the area of the injection site. Sometimes if a man injects the same place over and over again, you can get scar tissue at that area, which can result in some curvature. And then if you have a prolonged erection, you can have the side effects of that. I think it would be abnormal to have a reaction far away from where the injection was, unless you did have a prolonged erection. But that's something that I think that patient should talk to their prescribing physician.
Alrighty. So I know you just mentioned that if you use injection therapy repeatedly, you may experience some scar tissue. So what is the best advice you can give someone that injects consistently?
So if someone injects frequently, which I think is more than 2 to 3 times a week, I usually recommend patients choose different areas to inject, as long as they're able to do so. But that means alternating from the right side and the left side of the penis, and additionally using different spots up and down the shaft of the penis. So I know it's not. I'm gonna turn this way. The injection site can be anywhere from the man's kind of circumcision line or the coronal margin, anywhere here along 10 o'clock and anywhere here along 2 o'clock. You can go off like at 3 and 9, but the idea is you want to make sure that the needle goes into the corporal body and not into the urethra or under the skin. It needs to puncture into those erectile bodies, the same place where the penile implant would go, in order to be effective. Therefore, yeah, I would tell that patient to kind of alternate up and down this way and up and down this way, so you're not injecting the same place.
Alrighty. Following along with the injection technique questions, when I would draw the needle, sometimes it comes out bent. What am I doing wrong?
So a couple things, hard to know. And this is a patient that I think if they're pulling the needle out and it's bent, this is someone I'd say, come to the office and let me watch you do your injection and make sure you're doing it appropriately. But, from not seeing that patient, face to face, I would probably say they may be twisting their wrist a little bit or moving when the needle is inside the body, causing the needle to bend. As long as the medicine is depositing and the needle's not breaking, I wouldn't be very concerned about it. But yeah, that's a patient that I would say come in and make sure that when you do the injection, I usually have my patients hold it like a pencil or like a dart. So the needle goes. So I usually hold it like this. So not hold it on the back, but if you hold the needle, I'm trying to focus on here, sorry. Hold the needle like this, like a pen or like a dart like this, puncturing all the way in, and then only then when the needle is really hubbed and all the way in, then move your finger back to the back to push the plunger in. I think that gives you the most control, so you're not moving your wrist like this with the injection. Does that make sense?
Perfect. Alrighty, so I know you mentioned a side effect of injection therapy could be pain after the injection. What do you recommend for someone experiencing that?
So there's a couple options, and it depends on like what kind of pain that they're having with the injections. So if you have pain just at your injection site, so right where the needle goes in, sometimes it's just getting more comfortable with the technique, getting the needle in faster and not moving when you have the needle in. I do have some patients that will take some ibuprofen or before their injection. I do have some patients that will put a little bit of a numbing cream on the penis beforehand, so either an EMLA cream or a lidocaine spray that sometimes we'll use for premature ejaculation, and then put that on the penis so it deadens that skin a little bit, and then do the injection are options. But if after you do the injection, some men experience pain throughout the whole penis, and that can often be because of the medication itself causing the penis to dilate. Different medications and different formulas work a little bit differently. So that's a patient that maybe I would switch them to either a Bimix or try to reduce their percentage of PGE1 in their injection.
Alrighty, awesome. One final injection question here. Does wine or alcohol affect the results of your injection?
It really shouldn't to a significant degree. I mean, if you're really overdoing it with alcohol, it's possible that you aren't doing the injection appropriately or injecting the way that you should if you were sober. But outside of that, I wouldn't expect it to be a problem.
Alrighty, perfect. Moving right along, I got a couple of more specific questions here. So this person says they had a physical with their primary care physician recently. He's 62 years old, and he has had relatively high blood pressure over the past decade. His physician's now suggesting a blood pressure medication. What medication could he take that is compatible with tadalafil for ED?
I think almost any blood pressure medicine should be compatible with tadalafil for ED. There are some blood pressure medicines that can worsen ED more than others. Things like metoprolol or beta blockers tend to have worse erectile dysfunction side effects than some of the other ones. So a little bit of trial and error on that. But I really don't restrict my patients' blood pressure medicine use with tadalafil. The ones that you really can't take are nitrates or nitroglycerin with tadalafil.
Sweet. So following right along with a more specific question, while we're on the topic, this person says they're 71 years old. They had their prostate removed 8 years ago due to cancer. Oral ED meds are not helping his impotence. What are his options?
So that's a man who had a radical prostatectomy 8 years ago and has failed the oral therapy. I think that any of the options that we've discussed, except for the pills, are really options for them. The suppositories are reasonable. Injection therapy is reasonable. A vacuum erection device would probably work for this patient. And if those things failed, or if you're not interested in those other therapies, a penile implant is also an option.
Alrighty, awesome. And continuing on, we're going to be hitting some implant questions now. So first one, how many years do implants stay reliably working?
So the average implant usually lasts somewhere between 10 to 15 years. I mean, in my experience, I've seen them break at 2 years, and I've seen guys that are 20, 30 years after their implant and still functioning nicely. But I usually tell my patients to expect 10 to 15 years out of their implant.
Alrighty. Next question. What do patients typically say about the feeling of having an erection? How does it compare to a natural erection?
So most men and most their partners tell me that the erection that they get with a penile implant is the same as their natural erection that they used to have. Now, the way it's achieved is different, and pumping it is a challenge for some men to, get it inflated and to get comfortable with it. But the sensation with sexual activity for the man and for their sexual partner, the majority of my patients tell me is satisfactory and very close to, if not identical, to what they used to have.
Awesome. Alrighty. Next question here. Are circumcisions usually required with penile prosthesis?
No. If a man wants to have a circumcision at the time of their penile implant, I'm happy to do it. And I've done that plenty of times where a man says, I wasn't circumcised, but I'd like to be. I also have erectile dysfunction. I want a penile implant. Can we do both together? And I've done that plenty of times. But I also have many uncircumcised men that we will put an implant in them and leave them circumcised, and they're very happy with their end result.
Alrighty. Next question. I heard that if someone is getting an implant at the same time, they can get a bladder sling to stop leakage from prostate surgery. Is this true?
Yes, that's very true. So Boston Scientific, the manufacturer of the penile implant, also has two products that are there for men that have persistent leakage after their prostate's removed. So, maybe a very short is that when a prostate's removed, it's really common for men to have some leakage for up to a year after their prostatectomy, but about 10% of men have persistent leakage after that first year. About half those guys, would be candidates for some type of surgery. A bladder sling is a piece of mesh that goes under the urethra and gives extra support to the urethra. We often will do that surgery on its own or in conjunction with an implant. There's another option, which is called an artificial urinary sphincter. That's a cuff that goes around the urethra, so stopping the outflow of urine. It has a pump similar to what this penile implant is, but you squeeze a pump to allow the cuff to open up and the urine to flow. That can also be done at the same time as a penile implant, or it can be done separately or on its own.
Alrighty, moving right along. I see how the implants erect the shaft of the penis, but does the glans penis also get enlarged or engorged by the implant?
I'm trying to picture here. The short answer is no, that the glans or the head of the penis does not fill with the cylinders. The cylinders do end about halfway through the glans, and so the head of the penis is supported by the cylinders, but the head of the penis itself does not fill. And yes, that is one of the potential complaints of patients after the penile implant is in, is that the glans or the head does not fill. But the idea is to put the implant in a way that the head itself is supported by the implant.
Alrighty. Next question. What is the recovery time from implant surgery, generally and for sexual activity?
So penile implant surgery can be done either outpatient or with an overnight stay. I think about half my patients go home the same day, and the other half stay overnight. I usually leave a catheter in my patients to have them drained overnight. Some surgeons don't do that, but I think most of us do. Usually you have to really take it easy for about a week or two after the procedure. I recommend my patients stay away from heavy lifting or sports for about 2 weeks after surgery. I recommend that patients wait about 6 weeks after surgery to re-engage in sexual activity. In that kind of window between week 2 and week 6, I have my patients practicing with the pump, get comfortable with the inflation and deflation process, but I recommend not re-engaging in sexual activity until week 6 to prevent risk of infection.
Alrighty. One more implant question here. So this person says they just received a priapism surgery and only half of an erection is now possible. Would you recommend getting an implant?
That's definitely a patient that probably needs to talk to their the surgeon that did their priapism surgery, or to their local prosthetic urologist to really, get the details of what the priapism surgery was and how extensive it was, and kind of what the recovery process is and things like that, and assess how you're healing from it. But yeah, if you had a priapism and have persistent erectile dysfunction afterwards, then a penile implant is often the remedy for that. The newest guidelines from the American Urology Association really show that a man with a persistent priapism, so a priapism that lasts for more than 36 hours, the answer is to put a penile implant in that patient right away, because the odds of that patient regaining their erectile function is very low. But that said, in this patient that's recovered to some degree, some of it might be just tinature time to see if the ED improves, but a penile implant may be something worth considering.
Alrighty, awesome. Got a couple of Peyronie's questions here. So first question is generally aimed. What are some effective treatments for Peyronie's disease?
So Peyronie's disease is scar tissue in those corporal bodies, the erectile bodies that stretch to get an erection. And what happens is when there's scar tissue that forms, the penis then stretches everywhere else except for where that scar is located. And so what happens is when you get an erection, that scar doesn't stretch, so the rest of the penis does. You curve in the direction of where that plaque is. So men who have Peyronie's disease, this is a new thing, if it really just started setting in, sometimes this will get better on its own in a short period of time within the first 6 months. During that time, I usually recommend stretching the penis either manually, or you can order a traction device, which is a stretching device to help elongate that plaque. Men that have persistent problems with the curvature, there's a few options. There's Xiaflex, which is an injection into the plaque. This is the only FDA-approved medicine for Peyronie's disease, where you inject this medicine. There's a collagenase that breaks down that plaque. So it's a cycle of 2 injections, 4 different times, so a total of 8 injections into the plaque to break that plaque down and then stretch it so that it heals and more elongated. Other options for Peyronie's disease include surgical interventions, either doing what's called a plication procedure, where if the curvature is upward, you put a couple sutures in the bottom of the penis in order to shorten the bottom to really pull the penis in the opposite direction of the plaque, therefore not correcting the curvature, but correcting the angulation. There's also removal of the plaque, either with an incision or an excision, then putting a graft in. Or finally, a lot of times we'll do a penile prosthesis surgery for men that have Peyronie's disease, as well as erectile dysfunction.
Alrighty. Going to be reading some questions from the chat now, so they're not going to be generally organized by topic. Okay. But next question we have here: can you keep injection medications frozen beyond the 28 days? If you do, what happens? Or if you use them, I guess, after 28 days, what happens?
So I would recommend that you discuss with the pharmacy or the compounding pharmacy, or where you're getting your injections, about what the best way to store them. And I'll admit, different compounding pharmacies, different places where you get trimix or injection therapy medications will have different guidelines on their medication on what the best way to use it and freeze it and thaw it. I definitely tell patients that they should follow the manufacturer's guidelines, but truthfully, if you have a medicine that maybe is past that date, I think the biggest risk is that you'll give yourself your injection and the medicine has become less potent and you just won't get the desired effect.
Alrighty. Next question here. I haven't seen this one before. This person wants to know if there's any hope for men with post-finasteride syndrome.
So post-finasteride syndrome is a tough one. So finasteride is a really common medicine that's given for men with hair loss. It's also given to men with enlarged prostate to help shrink the size of the prostate. Very rarely men will get something called post-finasteride syndrome. It's about less than 1% is my understanding of men that take this medicine that have long-term side effects from the medication. Unfortunately, besides discontinuation of the medicine, there's really not any other treatment for post-finasteride syndrome, except for maybe treating it symptom by symptom. So if you have erectile dysfunction, treating it with these types of therapies that we discussed. Oftentimes it does cause ejaculatory issues or sex drive or libido issues. And then unfortunately, there's really not a cure that we know of at this time.
Alrighty. Going to be our last question here for the night. Can you remove scar tissue of Peyronie's at the same time as doing a penile implant procedure?
Yeah. So if a man has Peyronie's disease in conjunction with erectile dysfunction, or just purely severe Peyronie's disease, we can do a penile implant, and at that time do lots of adjuvant techniques. So sometimes we'll put the implant in and do different modeling types of maneuvers in order to just kind of fracture or break the plaque, and don't need to remove it. But sometimes if there's severe curvature, we can cut that plaque out, and sometimes have to put a graft in or a replacement tissue to allow appropriate healing. But yes, severe Peyronie's disease and significant plaque from Peyronie's disease can be corrected at the time of penile implant.
I'd like to thank Dr. Goldenberg for taking the time to present today, and we'd also like to thank everyone listening in for attending this MenMD The Focus webinar. We hope it was informative and you'll join us again in the future. If you'd like to learn more, you have a few options. There are more resources in the Resource Center on menmd.com. You can visit this page to view instructional videos, guides, expert articles, and more. If you'd like to contact MenMD support, you can do so by calling MenMD at 857-233-5837 or log into the password-protected, secure MenMD portal to schedule an appointment with a MenMD personal health assistant. If you'd like to compare any of the treatment options we covered during tonight's event, you can do this by going to menmd.com, navigating to the ED condition page, scrolling down to the treatment sections, and selecting up to 3 ED treatment options to compare. And finally, if you'd like to learn more about penile implants and insurance coverage, you can do so by visiting edcure.org. I'd like to thank everyone again for attending today's webinar, and we'll see you at the next one.